Okay, very good morning to everyone. Thank you for attending this early morning webinar series. As you may be aware, the World TB Day this year, the theme is on the 24th of March 2022. So in conjunction with the World TB Day this year, the theme created by WHO is Invest to End TB and Save Lives. This theme serves to convey the urgent need to invest resources to ramp up the fight against TB and achieve the commitments to end TB made by global leaders. We know in order to control TB, there are two important strategies required. Number one is to identify active TB, and in order to initiate the therapy as soon as possible. Number two is to identify latent TB with the intention to prevent TB reactivation. With us today, we have two very excellent speakers to enlighten us on topics related to latent TB. Before I introduce the first speaker, here are some housekeeping announcements. We'll keep the Q&A at the end of the session. Each speaker will speak about 25 minutes, and you may type your questions in the Q&A box in this Zoom platform. All right, we shall move on to listen to the talk by the first speaker. The topic is latent tuberculosis infection among healthcare workers. The question is to treat or not to treat. This will be delivered by Dr. Wong Kuan. He's currently the head of Division of Respiratory Medicine at the Department of Medicine in Faculty of Medicine. He's also the chair for the UMMC TB committee, and he's assuming the position of the consultant pulmonologist at Universiti Malaya Medical Center. So without further ado, I would like to invite Dr. Wong to deliver his lecture.
Thank you, Prof. Fang, for the kind introduction. Good morning, everyone. I'm very honored to be invited for this morning to deliver a lecture on latent tuberculosis infection among the healthcare workers. The questions that we would like to answer is whether to treat or not to treat. Before I start my lecture, I would like to share a case that I saw about 2 years ago. She's actually our staff working in the radiology department. She's a 30-year-old lady working as a radiographer, and she actually had a history of close contact with two of her colleagues in the same department that was diagnosed with a pulmonary TB about 2 years ago. Prior to her employment, she never had a TB screening done before, and nor a baseline tuberculin skin test was done. She was actually scheduled for ionizing radiation exposure screening in the staff health clinic and was incidentally found to have an abnormal chest X-ray, whereby she has a left upper zone reticular opacities, which suggestive of a pulmonary TB infection. Otherwise, she was asymptomatic. And there was a TST done, which shows a 10 millimeter indurations. And she was later confirmed to have smear negative PTB by means of bronchial alveolar lavage samples, which shows positive gene expert as well as positive MTB culture. So the question is, this patient actually presented to us with subclinical TB. Was there a better screening process to actually found this patient to have earlier onset of TB, and whether things like screening for latent TB initially and starting the patient on treatment would actually prevented her from getting a smear negative TB. So if she had not done an ionizing exposure screening, the subclinical TB would be missed, and she may actually progress into a full-blown active PTB and again spreading the infection to more staff. So this is the outline of my talk. What I'm going to do is to answer many questions that everyone would like to know. So first of all, I will actually try to answer what is the burden of TB disease worldwide and also locally as well as in our center. And what is latent TB infection and how high is the incident rate and how to diagnose the latent TB infections. And why do someone like me need to be screened and as well as be treated? And how is LTBI treated? And what are the risks of LTBI treatment? And what are the new services that is offered in UMMC currently to manage patients with LTBI? Okay, so I'm just going to tell all about a bit of the burden of a TB disease. TB is actually a preventable and a curable disease. Some of the patient or even some of the staff did not know that TB is a curable disease and thinks that this is a chronic disease and patient eventually will die. So in worldwide, TB is found to be one of the top 10 causes of infection that led to mortality. And in 2020 itself, it was estimated to have 9.9 million of TB cases worldwide. In Malaysia, we are considered to be an intermediate TB burden country. And for the last 2 years, we have seen a drop in the TB incidence rate, whereby in 2020, there were only 72.4 per 100,000 population. And in 2021, we have 67.4 per 100,000 population, way lower than the one documented in 2019, whereby we have about 93 per 100,000 population. Why is it so? This is because the COVID-19 pandemic had actually reduced the case detection rate for TB, and for sure, this will lead to higher TB mortality as a lot of patients will be found to be in advanced TB disease during the presentations. And we have seen a lot of patients, particularly the illegal immigrants, come in with a brought-in date. All right, so we'll see an increasing trend of higher TB mortality in our country. So what are the risks of us as a healthcare worker developing active TB? Based on one of the meta-analysis in 16 countries, they found that the incidence rate is about almost 3 times as compared to the general populations. And in Malaysia itself, we found that the incidence rate was about 135 to 156 per 100,000 populations, as compared to the neighboring country like Thailand, which they have 188 per 100,000 population, and in India, they have about 208 per 100,000 population of TB incidence rate among the healthcare worker. So Liu et al. Actually showed that during the year of 2012 to 2014, she found that the risk ratio for our healthcare worker to develop active TB is roughly around 2 times as compared to the normal general populations. And majority of our healthcare worker actually present with an infectious TB. 75% of that actually had pulmonary TB, and about 25% actually developed extra pulmonary TB. So this is the incidence rate of a TB infection in UMMC over the last 6 years. You can see we actually analyzed about 58 staff who actually have active TB during the last 6 years. And the incidence rate has been coming down over the last 2 years in 2020 and 2021. We are not so sure because of the pandemic, COVID-19 pandemic, that actually causes the reduction in the cases, or is it because of some of the active measures that we have done to reduce the incidence of TB among our healthcare workers? So the rate is still rather high. In the past, it was 206 in 100,000 staff, and currently it's about 103 per 100,000 staff. And out of these staff that develop active TB, we noted that nurses, attendants, doctors, and radiographers account for about 78% of those cases among the staff with active TB. And we also found that latent TB infection is one of the reasons the patient can develop active TB. These staff were actually screened throughout 2 to 3 years prior to development of the active TB. The other risk factor that actually increase the risk of susceptibility of developing active TB would be active smoker, diabetes, concurrent immunocompromised state, and also heart disease and respiratory diseases. And in this bar chart, the highest staff that develop active TB would be from the radiology department, followed by emergency department and the infectious respiratory ward, such as ward WP2. And also we have patients in rehab medicine department and also the security department. So what is the latent TB infection, and how high is the incidence rate? So actually, latent TB is an early spectrum of the TB disease. So it is defined as a state of persistent immune response, and it is due to the simulation of the Mycobacterium tuberculosis antigen. And the patient will have no clinical evidence of active TB, such as cough, loss of weight, loss of appetite, profuse night sweats, and the X-ray will be normal. There won't be any radiological changes of TB, and usually the sputum smear and also the culture will be all negative, right? So the patient do not have any clinical evidence of an active TB. So how do one actually get a TB infection? Human is actually found to be one of the only reservoir for MTB infection. And the infection is spread through air droplets, whereby the air droplets is as small as 1 to 5 micron. The activities such as coughing, sneezing, spitting, talking, and singing will increase the risk of spreading of the infections towards the other. And the air droplets actually can transmit as far as 3 meters. All right. So when the Mycobacterium TB actually enters your airways, it will actually be inhaled and go into your alveolus. All right. In the alveolus, if let's say the load of a Mycobacterium TB is large, you may actually get an infection. But if you let's say you have a good immune response, it can actually limit the mycobacterial activity, and the mycobacterium will survive, and they will remain dormant in the body and viable for many, many years. And subsequently, you will develop a condition called latent TB infection. But if let's say your immune response is unable to contain the bacteria, you will actually develop the active disease. What is the incidence of LTBI in worldwide? So WHO actually found out that 3 out of 10 of a person globally are thought to have a LTBI. All right, and for the healthcare worker, we actually have a median annual risk of latent TB infections, which ranges from about 3 to 7% annually. And how about in Malaysia? Rafiza et al. Actually found out that the prevalence of LTBI in the government hospital of the Klang Valley was found to be 10.6%. How is LTBI diagnosed? So when the patient is infected with a Mycobacterium TB, the Mycobacterium TB will actually present all these antigens to the T cells, and these T cells will actually stimulate the release of the all these mediators, particularly the interferon gamma. And when you do a tuberculin skin test, which is one of the protein of the Mycobacterium TB, and this will actually causes the release of interferon gamma to the skin, all right, and therefore causing a veil over the skin. And we can also detect the interferon gamma via the interferon gamma release assay, or we call it IGRA, and it is a blood test. And later, Prof. Nadia will actually describe to you in detail on this test. Tuberculin skin test is a very common test done. In fact, in UMMC itself, we've done thousands of tuberculin skin tests in a year. And it is, we usually use the purified protein derivative, which is cultured from an inactivated mycobacterium. And this PPD is actually injected intradermally, and it will form a small veil. And usually 72 hours later, we will read the induration, and if any induration is 10 mm and above, is considered to be positive. And the positivity can be as early as 2 to 8 weeks after exposure of a MTB infection. And there are many IGRA in the market, and some of those brand that is available would be Quantiferon TB Go test and also T-SPOT.TB test. So what is the sensitivity and specificity of these two tests? So the pool specificity of a tuberculin skin test in a BCG vaccinated population like us was found to be very low, which is barely 60%. And sometimes the findings of the tuberculin skin test can be heterogeneous. And as for the interferon gamma release assay, we found that about as high as the specificity of 96% in a BCG vaccinated population. Therefore, it is found to be more specific in patients with a BCG vaccination. But the problem is the cost of this test is higher as compared to the tuberculin skin test, and the cost can be as high as 20 times. So this is what are the possibility when you come for TB screening. All right, when you have the exposure with close contact of a TB infection, we will do a few tests, but before that, we will ask whether you have any symptoms at all. And if you do not have any symptoms, then we may proceed with a TST or IGRA test. And if you are found to be positive, you may be either having an LTBI, a subclinical TB infection, or an active TB infection. If let's say the X-ray shows a positive findings, then we have to work up for potential subclinical or active TB infection. And if let's say during the workup we found you to have a positive MTB culture or sputum smear positive, or in fact nucleic acid amplification test to be positive, then you are found to have a TB infection. If let's say you do not have any of the positive tests, you may actually just having a latent TB infection. So why do I actually need to be screened and treated? So we need to know what are the risks of developing active TB, and if you have a latent TB infection. A lot of study has found that the risk of developing an active TB in all these LTBI patients would be about 5 to 10% in their lifetime. And it is higher in the immunocompromised patient, whereby they can develop the TB infection within a year with the risk of 5 to 10%. So you also have to ask yourself whether you have higher risk of developing TB infection. For instance, if you work in a high-risk setting, such as the inpatient TB facilities, you work in the laboratory that deal with MTB culture, and also you work in medical department and also the emergency department. And if you work as a radiology technician, patient attendants, nurses, ward attendants, paramedics, clinical officers, laboratory personnel, and physicians, you also have a higher risk of getting a TB infection. So based on WHO, they actually classified the group of patients that require to be screened for LTBI. And particularly those patients with living with HIV, close contact whereby they are less than 5 years, regardless of their HIV status, and also adult and children who actually stays in a low TB burden settings, and also in some of the immunocompromised patients who actually do not have HIV infection. For instance, patients with who is on anti-TNF treatment, who is requiring dialysis, preparing for transplantations, and also those with concomitant silicosis. So this group of people should be considered for LTBI testing as well as treatment. And there's another group that they recommended to do a LTBI testing and treatment may be considered particular in a group that we're going to talk about, which is the healthcare worker. So how effective is the TB preventive treatment? It is found the treatment effectiveness was as high as 60 to 90% in reduction of the development of active TB, all right, with the current available treatment. How LTBI is treated. So there are many treatment options, but the treatment medication is on a few only, whereby we uses isoniazid, isoniazid plus rifampicin, or isoniazid plus rifampicin, or we can also use rifampicin alone. And the duration of treatment differs in each treatment recommendations. And the shorter the regime is found to be better because higher completion and compliance rate. All right. So therefore, there's strong recommendations on all these treatment options in prevention of an active TB infection. All right. So as you know, any medication will have their side effect, and the potential side effect for isoniazid would be increase in the liver enzymes, whereby there will be asymptomatic raise of liver enzyme of 5 times of the upper limit of normal. It's rather common, 10 to 20%, but usually this adverse event is transient, and a lot of time it will actually resolve on its own. The worrying part is patient may have clinical hepatitis. If you are using isoniazid alone, the risk will be 0.6%, but if let's say it's combined with rifampicin, the risk can go up to 2.7%. And patients with older age, underlying liver disease or viral hepatitis with a history of a heavy alcohol consumption and concurrent hepatotoxicity medication use, and patients with whose postpartum are having a higher risk of developing drug-induced liver injury. Okay, other potential side effect will be peripheral neuropathy. In healthy person, the risk is very low and probably can be negligible. But if patients have a concurrent medical problem such as nutrition deficiency, diabetes, HIV, renal failure, alcoholism, pregnancy, and breastfeeding, or on chemotherapy, they have higher risk of developing peripheral neuropathy. And the treatment usually is very simple by giving pyridoxine to as high as 50 milligram a day, or sometimes can be go up to as high as 100 milligram per day. Other potential manifestation would be CNS effect, lupus syndrome, and hypersensitive reactions. And the other important medication would be rifampicin. Rifampicin also found to have a higher risk of hepatotoxicity if combined with isoniazid. And the usually clinical hepatitis would be a cholestatic pattern. And some patients may have flu-like syndrome, but this is usually more common in patients who receive intermittent high-dose administration of rifampicin as compared to those daily dosing. All right. The other potential side effect of rifampicin would be severe immunologic reaction, which is fatal and in certain patients. So, but this immunologic reaction are rather rare, and the risk is less than 0.1%. Other important side effect that you need to warn the patient would be orange discoloration of the bodily fluid, whereby the patient may be permanent, the sputum, the urine, the sweat, and the tears may actually permanently stain their clothes, and also if let's say they are wearing a contact lens, the contact lens may be permanently stained. So now we come to the last outline of the talk, which is what are the new services offered to the UMMC community. So this year, the World TB Day theme would be invest to end TB and to save lives. And we are actually investing in our UMMC community to end TB. So since 1st of November, we actually started a UMMC healthcare worker LTBI clinic, and it falls in every first and third Monday of the month in the afternoon, and it is run by 2 chest doctors, 2 staff health clinic doctors, and 2 staff nurses. So in the picture, as you can see, team from JKA, from OSHI, from CHEST, as well as from the staff health clinic are there to actually handle this clinic. And in one clinic session, we actually see about 30 of them. And these are the objectives whereby we want to actually screen the healthcare worker to treat them and also to prevent the spread of the TB infection in the hospital setting. And all those staff will actually meet the criteria of TB screening will be actually screened for latent TB and active TB, and to be seen in the clinic. All right, and they'll go through a set of education which comprise of an e-learning module, which was developed by the OSHI. And there will be a lot of assessment and to see whether they have an active or latent TB infection, and they'll be counseled for treatment. And in this what you call clinic, we actually found out that about 32.7% of our cases of our healthcare workers actually have latent TB infection in 2020, and about almost 19% actually have LTBI in 2021. And the staff from A&E, radiology, and also the ICU and CCD has the highest number of LTBI. And based on job category, staff nurse is found to have the highest risk of developing LTBI, followed by radiographer and attendants. And we have seen almost about 57 of them out of the 178, and almost half of them actually, decided to be treated, but the other half decided not to be treated. So in summary, TB is a preventable and curable disease, and COVID-19 pandemic actually affected the TB case detection rate, which leads to higher TB mortality. Healthcare worker actually has a 3-fold risk of developing TB disease, and the annual risk of developing LTBI of as high as 7%. And LTBI treatment is effective with low risk of adverse effect. And investing in a better screening program will actually help to reduce TB cases in hospital setting. And UMMC healthcare worker LTBI clinic serve as a one-stop center for management of staff with LTBI. Okay, that is the end of my talk, and thank you for your attention.
Okay, thank you very much, Dr. Wong, for the very enlightening talk. Well, after going through the background of latent TB, and then talking about who are at risk, how high is the risk for, in particular for healthcare workers, how to identify them and how to diagnose them using IGRA or the older test, the tuberculosis skin test. We shall now dive deeper into the laboratory investigation. Just now you heard a lot on this IGRA, and one of them is the TB, the T-SPOT.TB test. So for that, we'd like to invite our second speaker. She's none other than the Associate Professor Dr. Nadia Atiya from the Department of Medical Microbiology. She's currently the Deputy Chair for the UMMC TB Committee, and she's also the Clinical Microbiologist for Universiti Malaya Medical Center. She's going to talk about a single visit blood test for latent tuberculosis infection diagnosis. So, Dr. Nadia, the screen is yours.
Okay, hello, good morning, everyone. So thank you very much to Prof. Pang for the very kind introduction and for moderating this CME. So the talk that I'll be giving at this morning's breakfast at UMHealth CME is on the T-SPOT.TB assay, which the Department of Medical Microbiology has started offering as a test for latent TB detection at UMMC. Okay, so latent TB infection or LTBI is typically defined by the presence of an antigen-specific T-cell response in the absence of clinical symptoms. So it includes conditions ranging from clearance of the pathogen, maintenance of quiescent infected foci to active subclinical disease, and can actually be viewed as part of a spectrum of outcomes to infection with Mycobacterium tuberculosis. So although individuals with LTBI do not have clinical signs and symptoms of active TB disease, as Dr. Wong had mentioned, in the absence of treatment, approximately 4 to 6% of such individuals will develop active TB disease during their lifetime. And the likelihood of progression to active TB infection is greater in certain groups of individuals that have a reduced ability to contain Mycobacterium tuberculosis, including young children less than 4 years of age, those with underlying conditions associated with immunosuppression, especially those with HIV infection. So the aim of LTBI testing is to identify those who will benefit from preventive or prophylactic therapy. So this would be individuals who are at risk for new infections, such as close contacts of patients with untreated active respiratory TB, and individuals at risk for progression from latent to active TB disease because of underlying conditions like HIV infection. So there are two major tests for latent TB detection, including the tuberculin skin test or TST, which Dr. Wong had already mentioned, and the interferon gamma release assays or IGRAs, which include the T-SPOT.TB test and the quantiferon assays. So both TST and IGRAs, both of these tests evaluate cell-mediated immunity. So they measure immune sensitization to mycobacterial protein antigens that might occur following exposure to an infection by mycobacteria. So the TST usually becomes positive within 4 to 10 weeks after TB exposure, and an IGRA test usually becomes positive within 4 to 7 weeks after TB exposure. So just to mention that while IGRAs and the TST can be used to aid in active TB diagnosis because they cannot distinguish between latent TB infection and active TB disease, they should not be used to confirm the diagnosis of active TB, which is still a microbiologic diagnosis requiring AFP smear and AFP culture. So the TST, which Dr. Wong had already mentioned in great detail during his presentation. So this is a skin test that can be performed in the clinics, and because of its low cost, it's a cheap test to do. It is currently the most common test used by physicians in our part of the world to detect individuals with LTBI. So this test identifies individuals who have been previously exposed to mycobacteria, and it's performed by injecting a substance called purified protein derivative or PPD, which is an antigen derived from Mycobacterium tuberculosis. So it's injected into the inner surface of the forearm, and this will stimulate a type 4 or a delayed type hypersensitivity response that's mediated by T lymphocytes, and this will cause thickening of the skin, referred to as induration, within 48 to 72 hours. So then the transverse diameter of the induration is measured and recorded in millimeters. So the biggest limitation of the TST is that it requires patients to return for a follow-up visit 2 to 3 days later for the test result to be read. So until recently, the TST has been the only method to test for latent TB infection. The interferon gamma release assays or IGRAS are newer tests for LTBI detection. So they measure the release of a cytokine called interferon gamma by sensitized T cells in response to antigens that are highly specific to Mycobacterium tuberculosis. The two well-established IGRAS that are approved for use, there's actually a new one that's just been approved by WHO, but I won't talk about the test. So there are two well-established IGRAS that are approved for use and are commercially available, and they are the quantiferon TB gold in tube test, or the QFT-GIT, and the T-SPOT.TB test. So IGRAS versus TST. So, a lot of people wonder which is the better test for LTBI detection. So both tests actually have their advantages and limitations when it comes to LTBI detection. So the major advantages of the TST are that it is relatively easy to perform because it does not require a laboratory, it does not require equipment, it is cheap, and you don't need to collect blood. The major limitations of the TST include the need for a follow-up visit to have the test results read, the occurrence of false positive results due to the cross-reactivity of the antigens within the purified protein derivative used in the TST to both the BCG vaccine and non-tuberculous mycobacteria. So the test specificity of the TST is decreased among individuals with prior BCG vaccination, especially those who were vaccinated post-infancy and those who had received repeat BCG vaccination. So the main advantages of IGRAS, so both the T-SPOT and the quantiferon assays over the TST, is that they only require a single patient visit to conduct the test. Okay, so they do not require a second visit for reading of the results. In terms of the limitations of IGRAS compared to the TST, and this apply to both the T-SPOT and the quantiferon assays, they are much more expensive than the TST due to the reagents and equipment involved. So in a systematic review, so just to share, in a systematic review and meta-analysis that was published in the Lancet journal in 2019, that analyzed 40 studies comprising of 50,592 individuals in 41 cohorts that assessed the predictive value of IGRAS and the TST for the progression of latent infection to active TB disease. IGRAS were actually found to have a better predictive ability than TST. Now I'm going to talk a little bit in detail about the T-SPOT.TB assay. So we know that the immune response to infection with Mycobacterium tuberculosis is mediated predominantly through T cell activation. So as part of this response, T cells are sensitized to Mycobacterium tuberculosis antigens, and the activated effector T cells, both your CD4 positive and CD8 positive cells, will produce the cytokine interferon gamma release, interferon gamma, when stimulated by these antigens. So the T-SPOT.TB uses the enzyme-linked immunospot or ELISpot methodology to enumerate or count Mycobacterium tuberculosis sensitized T cells by capturing interferon gamma in the vicinity of T cells from which it was secreted. So the test is performed on separated and counted peripheral blood mononuclear cells, or PBMCs, which include circulating lymphocytes and monocytes. So when a blood sample is received for testing, we will first separate the peripheral blood mononuclear cells, or PBMCs, from the blood sample, then wash and count them. We then put the PBMCs into the wells of 96 well microtiter plate. the plates are pre-coated with high affinity antibodies to interferon gamma, which I mentioned is a cytokine released by effector T cells when fighting TB infection. 2 Mycobacterium tuberculosis specific antigens are CFP10 and Ep.6 peptides. So these are antigens that are very specific to Mycobacterium tuberculosis. So they are added to the wells, and the PBMCs are incubated with these 2 antigens to allow stimulation of interferon gamma secretion from any effector T cells primed against TB. So these 2 antigens, like I mentioned, they are very specific to Mycobacterium tuberculosis. So this allows for only responses of T cells specific for TB to be measured. So antigen-specific responding T cells release the interferon gamma, which is then captured in the immediate vicinity of the T cells by the antibodies lining the bottom of the wells. After incubation, the wells are washed, which will remove the antigens and cells from the wells, and then conjugated second antibody is then added, which binds to the interferon gamma secreted by the T cells captured by the priming antibody. We then add a substrate which produces spots where the interferon gamma was secreted by the T cells. So the spots that form essentially represent activated T cells that produce interferon gamma. So how do we interpret the T-SPOT results? So I'm not going to go into too much detail, but just very briefly, like I mentioned in my previous slide, what the T-SPOT test basically does is it measures the number of interferon gamma producing T cells. Okay? So an individual is considered positive on the T-SPOT test if the number of interferon gamma producing T cells, or what we refer to as the spot counts. So each spot that you see actually represents an activated T cell that's producing interferon gamma. So we actually count the spots, and if the spot counts in the TB antigen wells, which contain the CFP10 and the Ep.6 peptides, exceed a specific threshold relative to the control wells, okay, the nil control wells, then the individual will be considered positive. Now, it is important that any T-SPOT results are interpreted with other relevant clinical information. So this applies to any laboratory test result. It needs to be interpreted with the patient's history, epidemiological history, and other investigation results. And this is because false positive and false negative T-SPOT results can occur. Okay? So for example, false positive T-SPOT results can be due to infection with certain non-tuberculous mycobacterial species. False negative results can occur due to reasons such as incorrect blood sample collection, improper sample handling, or testing too early in the infection. Now, if a patient has recent exposure to a TB-infected individual or has other relevant clinical history that indicate possible latent TB infection, but the T-SPOT test result is negative, we would recommend retesting the patient within 6 weeks, okay? Just in case the first result is a false negative. Now, if the result is uninterpretable, so sometimes we can get results that cannot be interpreted, so they're either borderline results or invalid results, we would recommend repeating the testing using another blood sample. So we would ask you to give us another blood sample so that we can do the testing again. Yeah. So these borderline or invalid results, we can get results like this if there is a reduced T cell response in the positive control. That will actually give you either a borderline or invalid result. Okay, so just to highlight a few important things about the T-SPOT TB test that we just started offering at UMMC yesterday. So the requesting clinician needs to be a specialist or consultant. Okay, so for now, it needs to be a specialist or consultant, and the request for the test can be made by the iPer system under EMR. So in terms of sample requirements, a venous blood sample needs to be collected in a lithium heparin tube. So this is the light green top tube, which contains lithium heparin and a gel separator for the collection of heparinized plasma. So because sufficient peripheral blood mononuclear cells or PBMCs are required to run the T-SPOT assay, we would require a minimum volume of 6 ml of blood for adults and children 10 years and older. For children 2 to 9 years, it's minimum 4 ml. And for children less than 2 years, we would require a minimum volume of 2 ml of blood. So collected blood samples need to be stored at room temperature. Okay, there's no need to refrigerate the samples, and they should be sent to the Department of Medical Microbiology, which is located on the 5th floor of Menara Timur, by hand by 12 p.m. on the day the samples were collected, so that we can start running the assay in the afternoon. We can start processing the samples in the afternoon. For now, we will only be accepting samples received from Mondays to Thursdays. Yeah, for T-SPOT testing, we won't be accepting samples on Fridays, Saturdays, and Sundays. So the reason being is because we need to carry out the T-SPOT test in the afternoon and continue on the morning of the following day. So this is due to the 16 to 20 hour incubation step of the assay that takes place overnight. So we don't have laboratory personnel at the moment available on Fridays and the weekends to continue processing the samples for the T-SPOT test if we receive it on a Friday or on the weekends. So we put the turnaround time or the TAT as 3 to 5 days. However, we should be able to report out most results in the iPerCircuit system within 48 hours from the time the sample is received by the microbiology department. So the longer TAT stated is just in case there are samples that need to undergo repeat testing, or we might need a bit more time to verify the results. So the T-SPOT test is considered a special test at UMMC, so it's parked under the UMMC Business Development Unit. So the price of the test is 290 ringgit. So as far as I understand it, healthcare workers will be exempted from paying for the test, but for other individuals, the test needs to be paid for first before we can proceed with testing. Okay, so T-SPOT versus the quantiferon assays. Yeah, so this is a question that I get a lot from my colleagues in the wards, in the clinics. So what are the major similarities and differences between these two interferon gamma release assays or IGRAs? Because both are IGRA-based tests. Yeah. So both the T-SPOT and the quantiferon assays can demonstrate prior TB infection. So they can be used to identify those with latent TB infection. Both of these tests involve collecting fresh blood samples and incubating them with TB antigens and controls. For the T-SPOT test, blood must be processed within 8 hours of collection. However, if a special reagent is used, which we can actually purchase from the company, called the T-cell extend reagent, then whole blood can actually be stored up to 72 hours prior to processing. For quantiferon, blood samples must be processed within 16 hours. Now, the T-SPOT test, which I already mentioned how it works, it measures the number of interferon gamma producing T cells, whereas the quantiferon measures the concentration of interferon gamma. T-SPOT utilizes two antigens that are specific for Mycobacterium tuberculosis, so CFP10 and ESET6, while the quantiferon assays utilize peptides from 3 TB antigens, CFP10, ESET6, and TB 7.7. So unlike quantiferon, the T-SPOT assay includes a borderline category. So the inclusion of a borderline category in the T-SPOT assay, which you will not see with the quantiferon assays. So this borderline category reduces the likelihood of false positive or false negative results around the test cutoff. So overall, IGRAs, so both the T-SPOT and the quantiferon assays both have a specificity of greater than 95%. In terms of sensitivity, the T-SPOT and the quantiferon assays, the sensitivities would be approximately 90% and 80% sensitive respectively. Okay, so just to share some findings from our recently published papers on the different tests for LTBI detection. So in a systematic review that analyzed studies on T-cell based assays for LTBI diagnosis, the authors found that the T-SPOT.TB assay is more sensitive than both the quantiferon test and the TST. Systematic review and meta-analysis on the IGRAS for the diagnosis of LTBI in HIV-infected individuals found that the T-SPOT.TB assay is less affected by immunosuppression than quantiferon and the TST. Now, this was a study that compared the diagnostic performance of the T-SPOT.TB and quantiferon assay, and the study found that T-SPOT.TB has a higher, not only has a higher sensitivity compared to the quantiferon assays, but it also results in fewer indeterminate results. Okay, so as I mentioned earlier, the main advantage that both the IGRA test, the T-SPOT, the quantiferon assays have over TST is that they only require a single patient visit to conduct the test. Yeah. Now, T-SPOT versus quantiferon. So although the cost of the quantiferon test in Malaysia is slightly cheaper than the T-SPOT test, based on the findings of the studies I mentioned in my previous slides, the T-SPOT test has, a few important advantages over the quantiferon assays. Yeah, so the most important being is the higher sensitivity of the T-SPOT test, so approximately 90% sensitivity for T-SPOT and approximately 80% sensitivity for quantiferon. So the higher sensitivity of the T-SPOT test is most likely due to the testing platform, which ensures that an adequate number of peripheral blood mononuclear cells or PBMCs are available, even if the individual that we're testing has low lymphocyte cell counts. So this higher sensitivity of T-SPOT makes it especially useful for assessing or testing individuals with immunosuppressive conditions. The T-SPOT test also appears to give or yield fewer uninterpretable results compared to quantiferon. So uninterpretable IGRA results refer to invalid and borderline results in the T-SPOT assay and indeterminate results in the quantiferon assays. Yeah? So as I mentioned earlier, uninterpretable results may be due to various factors, but it's usually associated with immune suppression, which can lead to a reduced T-cell response in the positive control. So T-SPOT actually gives fewer uninterpretable results compared to quantiferon. So that's one of its advantages. Now, in terms of limitations, the T-SPOT test and the quantiferon assays, they do share similar limitations. However, quantiferon, as I mentioned when I was talking about the advantages of T-SPOT, quantiferon has additional limitations when compared to the T-SPOT. Yeah? So it's less sensitive than the T-SPOT test. And one thing I did not mention in my previous slide is that with the quantiferon test, it requires batch testing, whereas with the T-SPOT test, we can actually test individual samples and without batch testing. So in summary, the T-SPOT.TB test is a useful single visit blood test for the diagnosis of latent TB infection. Unlike the TST, it does not require a second visit for the test results to be read. It has a number of important advantages over the quantiferon assays and the TST, including a higher sensitivity and fewer uninterpretable results. The T-SPOT test also appears to be less affected by immunosuppression compared to the quantiferon assays. So lastly, just to emphasize that latent TB infection is a clinical diagnosis that is established by demonstrating prior TB infection and excluding active TB disease. So due to the possibility of false positive and false negative T-SPOT results, it is important that T-SPOT results are interpreted with other relevant clinical information such as the patient's medical status, epidemiological history, and the results of other investigations. Okay, so I would like to end my talk by acknowledging my head of department, Professor Jamal, Ching Sam, members of the T-SPOT.TB team, the staff at the Diagnostic Microbiology unit, who were very instrumental in getting the T-SPOT test off the ground. And we also received a lot of technical support and guidance from Oxford Immunotech and Biomed Global, who are the companies that manufacture and distribute the kits in Malaysia. So they were very helpful in training the T-SPOT team at the Department of Medical Microbiology, UMMC. So thank you very much.
Okay, thank you very much, Prof. Nadia, for sharing your insights on the IGRA, particularly comparing the T-SPOT versus the quantiferon test. I hope we have a better understanding after Prof. Nadia's talk. We have received quite a number of questions in the Q&A box. We shall go straight to the Q&A. So the question is open to both speakers. The first question is, Doctor, do we have IGRA tests in UMMC? I think Prof. Nadia just informed us in the lecture that the IGRA test is officially available now. I think, but at the moment, it is still limited to the specialist request, and patients have to pay 290 ringgit for the test. Okay, so let's move on to the second questions. Does TST or IGRA screening among exposed healthcare workers must be followed by chest X-ray? Is it compulsory, or does the screening can stop at TST level only?
Yeah, thank you for the question. So if let's say the staff has a positive, either a TST or IGRA, definitely they will have to get a chest X-ray done. So this is a screening test, right? So if let's say they do not have a positive TST or IGRA, then we don't really proceed with a chest X-ray unnecessarily.
Okay. Thank you for the answer. Next, do we need to treat exposed healthcare workers for latent TB infection if they had negative TST but positive IGRA?
Sorry, again, Prof, is to treat the latent TB exposure. Which question is this again, Prof?
This is actually to say if they have a negative tuberculosis skin test, but they have positive IGRA, do we treat, or do you consider this as latent TB in the first place?
Yes, we consider this as a latent TB in the first place because there are also cases of a false negative TST. All right, yeah. So it's more specific in sense of doing an IGRA test.
All right, next question. Do we treat all latent TB infections? But I think example given here is those with incidental tuberculosis skin test more than 10 mm due to contact screening, but asymptomatic with normal chest X-ray, or just those with high risk.
Okay, for these questions, we always keep on asking us whether to treat all or just to select some of those staff. If let's say you are actually working in a high risk working setting and you are a high risk category, job category, then for sure we will actually counsel you for treatment. And especially if you have a recent close contact with a colleague with active infectious TB, right? So we will actually offer treatment. Of course, not all will actually agree. Some may decline for many circumstances, like they may want to actually complete their family. They may actually have other medical problem with concurrent medications, and they are worried. So all this has to be addressed, and they actually have to know the risk of developing active TB and also the risk of side effect from the anti-TB medication. And for sure, this group of staff will be monitored for the next couple of years, just to make sure that they don't develop subclinical or clinical TB. And if let's say they are found to have, they are early detected and then early treated to prevent the spread of the infection.
All right, thanks for the answer. Does doing MEN2 affect the IGRA result? How long after MEN2 can IGRA be done?
Maybe Nadia?
Yeah, so I think at the moment there's no really optimal approach to like serial testing, but I think there was a recent systematic review that showed that the TST actually doesn't significantly boost IGRA test results. So yeah, I think that would be my answer. I mean, if the worry is about the TST boosting IGRA results, then studies have shown that it doesn't significantly boost.
Okay. So I think the idea is not to do both tests. You should just limit yourself to just do one of them. Because the problem is when you do both, something can be very confusing. Okay, maybe we should go to the next question. How do you treat latent TB in patients with G6PD deficiency?
Okay, so based on the memes, right, this isoniazid have potential risk of causing a hemolysis. So if ever the patient found to have G6PD deficiency, then we should try to avoid isoniazid, and maybe we can use a rifamycin regime to manage.
Yeah, because as what you can see just now, Dr. Wong shared with us that they are actually all in all 4, I think just now you shared 4 regimens, right? Recommended by WHO. So I think the next question also related to this, are we getting rifampicin as part of the treatment of latent TB? I mean, the argument is the treatment duration is shorter and it's a weekly dosing. You only need to give 12 doses.
Yeah, of course, if we have the medication in Malaysia now, then obviously this will be one of the choice, because shorter duration and only patient have to come for a weekly visit to take the medications, and definitely the compliance and completion rate is secure. So, but the cost of using rifampicin would be higher, as I guess one tablet costs about $1 USD, and therefore because of the cost price, that's why it's not used yet. But the other regime that they actually propose will be 3 months of isoniazid plus rifampicin. That will be actually good as well, because of the shorter duration of treatment. Yeah.
Okay. Yeah, and also I think if I may add, the rifampicin isoniazid has to be done under docs, whereas the isoniazid rifampicin you can prescribe and then the patient can take at home. So I think there are some differences over there. Okay, here one of the participants would like you to clarify in terms of the duration of latent TB treatment, particularly in relation to isoniazid and rifampicin. You mentioned that actually the isoniazid rifampicin 4 months, I think based on CPG, 3 months actually recommended by WHO. Which one is a correct duration?
Yeah, we have revised our CPG. It's going to be launched in May. Likely, we're going to suggest 3 months of INH rifampicin as what we're going to follow the WHO regime.
Okay. So the next one, I think this one is about IGRA again. What is the minimum age that we can perform this IGRA? The MMR has effects. Does MMR has effects on TST result? How about IGRA? How long after MMR can we do IGRA? Maybe Nadia can help to answer these questions.
I'm actually not aware about the MMR vaccine or whether it has any effects on the IGRA test results. I'm not too sure about that. I do not know whether Dr. Wong, as far as I know, no.
Yeah,
I think this must be from the pediatricians. Unfortunately, I'm also not a pediatrician, so I'm actually also not any wiser.
But I think I'm not too sure what the new MOH TV guidelines will be recommending. I think maybe Dr. Wong would know better. But I think if you go with go by the recommendations that are in the current IDSA guidelines, I think the IGRA is considered an acceptable test even in children who are 5 years and younger. So even though I think TST is still preferred in that age group.
Yeah, as far as I know, the pediatricians still prefer the TST than the IGRA, although it can be done in children younger than 5 years old. But you have to interpret this cautiously. Okay, let's move on. Can a previously active TB person have negative IGRA?
Yeah, so the IGRA test can be positive despite after treatment. So it doesn't actually wane off the sort of like the IGRA result. We have studies shown that the patient have a positive IGRA test despite after 20 years of treatment of a TB. So it's actually can be still positive.
Yeah. So the short answer, it can still be positive, but on the other hand, it can become negative as well. So either way, but we are not using the IGRA to monitor the response to treatment. So next question, is it recommended for less than 5 years old to take IGRA for screening? I think this one we have more or less addressed just now, or Nadia, do you have any other additional answer for this?
I don't actually. Yeah, it's what
Okay, yeah. So you can do, but then I think at the moment, as far as I know, the pediatrician is still very much in favor of the tuberculin skin test. Okay, next question. I think also pediatric question. 8 months old baby taking 3 months of isoniazid rifampicin for household contact. And the baseline ALT is 24 unit per liter. After 3 weeks of isoniazid and rifampicin, ALT increased to 96. Should the baby stop the treatment or change to rifampicin regimen? Or shall we test again after 1 week?
I don't think I'm the best person to answer this because this is a pediatric group. Well, I don't think so. I can answer this on behalf of the pediatrician. Yeah.
All right.
What do you think, Prof?
So yeah, but this patient was given 3 months of HR, right? And then after 3 weeks. So it depends on actually what we are using it for. I think sometimes this HR, this is actually, I think you have mentioned that we can actually choose the lesser regime, the rifampicin. If the patient ever develop significant liver toxicity, perhaps I think the alternative regime like rifampicin might sound like a reasonable options. So, but I think maybe we need a pediatrician to verify this. I mean, that's just my personal view. The next question is, would the pre-analytical requirements be available in EMR? Be available in EMR upon ordering, as the requirement sounds complex, especially based on each group. So I think this one is addressed to Prof. Nadia.
Yes, yeah, I do agree that the sample requirements are complicated. So yeah, we'll definitely put them in the instructions and in EMR, so that will be clear for everyone.
Yeah, I think how nice it is. I think in future the EMR will also have some guidance on clinical decision making, right? The AI built inside, so they can guide the clinicians on the test result and a lot of other things. Well, I think we shall see that actually maybe not in a very far future. And the next question is, would you recommend T-SPOT.TB test on all healthcare personnel? It's a very tough question.
Yeah, it's a very tough question, and we actually wanted to do this. In fact, we have discussed this in our what you call MSc meeting. Yeah. To decide on actually who should be tested Obviously, the one working in a high risk work setting and also high job category, those are the one that we're going to choose. For the low risk, we wouldn't actually do it unless they are close contact of an active infectious TB. And definitely, we will still use a TSC as a screening test because it's cheap. We found out that it's about RM5 per test if you say you are doing in batches, right? And therefore we will not be able to do all the T-SPOT tests for all the healthcare personnel. But if let's say if the screening TSC turns out to be positive, not really positive, like just a borderline like 10, and the person actually very worried whether should be treated or not. So sometimes we can actually offer this kind of test. That's what we are trying to do now. But in future, we would like to actually offer this test as a one screening test for healthcare worker with close contact. All right, and that I guess will be a better what you call strategy. Yeah.
Okay. So, we also know that the TST is not ideal if the test need to be done repeatedly, because we have this risk of the booster effects, meaning that the repeated the mental test might get actually bigger and bigger. So it's a bit difficult to interpret. Ideally, I think the T-SPOT test, as what Prof. Nadia mentioned just now, will be the ideal screening test for healthcare workers. And also, if we are going to do it on the annual basis, so-called the surveillance, then I think the T-SPOT test will be just the right test. The cost, of course, I think is an issue. But then if you are limited to, I think what Dr. Wong mentioned, only to a high-risk area, particularly to look at how good is our infectious control measure in the hospital, I think it's definitely worth the money. We have spent so much money in COVID-19. We used to say we have no money, but suddenly government is allocating so much money in fighting COVID. TB is actually the so-called the step child. So I think we probably should push for it. Next question: if a staff who was treated for latent TB years ago, having another new TB context, right, and screening confirmed latent TB status, would you consider repeated treatment for latent TB? So I think this is a very relevant question. How do you address this? Because once tested positive, treated, and just now I think that from the discussion, Dr. Wong mentioned that it may become positive or may become negative. So how do you know that the patient got another round of infection?
So we wouldn't know. What we're going to do is just monitor the staff over the next 2 years. And if ever they have a symptom, then we actually have to investigate whether is it due to TB or not. Because we wouldn't know that the positive agar test was secondary to the previous TB infection or the current TB infection. But of course, that's why all these people who was treated with LTBI, they have to know the SOP of prevention of TB. Okay, then they they are preaching the SOP, and we'll have to questioning them why you are.
Can you repeat just now? I think your internet connection was interrupted.
Oh, right. So I was saying, where was I until you can hear that?
Just the last sentence.
Oh, right. So for the staff who actually develop the latent TB infection, if they have another contact and develop active TB, we will have to ask whether they actually abiding the SOP for TB prevention. So we are actually educating our staff importance of TB prevention by other means, and not just by testing and then get treated.
Yeah, so I completely agree with that view. Treatment is just one part of the strategy. The most important thing is actually to emphasize on the TB prevention, right? So that we don't get repeated latent TB infection. So just now, I think the question was asked regarding the IGRA test for healthcare workers. I think we probably need to convince the hospital administration to lend us actually the ability to test it. Okay, so I think this is the last or second last question. If doctor perform MEN2 tests on low risk patient, and this patient have no history of close contact, and it came out to be positive, let's say the MEN2 is 10 nm, do we treat them?
So this patient or staff probably may get it from a community. If let's say this is a confirmed latent TB, but of course, MEN2, as what we mentioned just now, is not so specific. If it's an IGRA test is positive, and it can be due to the patient might be getting the infection from community and not necessarily from the workplace. Okay.
Yeah. So if I may add, I think that's the reason why I think we are doing this targeted latent TB screening. So if there's no risk, please don't screen, because then you end up with this kind of dilemma to treat or not to treat. Yeah. So I think we often emphasize actually you probably target the high risk, but like close contact, and because the risk of reactivation is also higher within the 2 years, or some even say that within 5 years of the close contact. Okay, but if let's say beyond that, the risk of reactivation is actually quite low. So there's no reason to do random screening. Okay, so this one, I think the next question, maybe Nadia, you can answer. Could any primary immunodeficiency disorder affect the IGRA results?
Yeah, I mean, any disorders that are associated with immunosuppression, immunodeficiency can affect both the TST and the IGRA test results. However, as I showed you that the results from the study during my presentation, the T-SPOT test appears to be less affected by immunosuppression compared to the quantiferon as well as the TST. So if you're assessing individuals who are immunosuppressed or who have some sort of immunodeficiency disorder, you might want to consider using the T-SPOT.
Yes. Thank you very much for the answer. Yeah. So yeah, immunodeficient, they may affect, but then T-SPOT compared to quantiferon is still a better test in identifying the presence of latent TB. Maybe the last question, probably not so much of latent TB, but here someone asked actually, is there a requirement to repeat sputum EAB after 2 weeks of treatment initiation? If yes, if EAB is still positive, does that mean that the healthcare workers still need to be isolated? This is probably talking more on active TB. Yeah. Right, Dr. Wong?
For us, because we are very careful with infectious TB, if ever you have a smear positive PTB, and we will actually isolate you or home isolation until you actually sputum converted, because we wouldn't want to pose infection to the other staff. And therefore, rest assured that the staff who actually contracted TB are allowed to have a sick leave. All right, you are given a medical certificate as long as on treatment, and depending on whether you are fit to go back to work. So the physician will decide, not just based on sputum, but sometimes some of you can develop a side effect out of the anti-TB. We also actually give a longer period of MC. So to answer your question, yes, patients still have to be isolated, and we will only release you back to work until you are sputum converted. Because we do not sure whether your sputum, the AB positive, are still a viable AB. We only can actually do a culture to confirm whether it's viable or not. Yeah, to be safe, we actually have to isolate you.
Yeah, I think agree with that. I think I suppose the reason why this question was asked is that I think most of the time we say, okay, after 2 weeks, maybe the patient is rendered non-infectious, but not just for anybody. Yeah, patient with I think heavily positive EAB and multiple cavities, they can still remain infectious even after 2 weeks. And because the healthcare worker, we are dealing with a lot of ill patients with multiple comorbidities, and some of them immunocompromised. So it's a different consideration compared to those patients that we actually treated. So I think with that, I think we have to end this session. We are running a bit late. It's already 9:20. So let me just sum up the session. I think we have a very fruitful discussion on latent TB. This condition is often underappreciated, but I think nonetheless constitute one of the most important source of continuing TB spread in the community, of course, hospital included. So I hope after this lecture, the audience would have a better understanding of a latent TB infection, how to identify them, how to treat them before the TB bacilli even have a chance to reactivate. So I would like to thank both speakers for their very educational and enlightening talks. And for the audience out there, thank you very much for logging in to join us this morning and for asking the many relevant questions to make this session more interactive. So have a great day ahead. And until then, see everyone. Okay, thank you. Bye-bye.
Thank you. Goodbye.